is always follow tradition. So adana ingalode technology, this is the concept. If you follow the concept, this file is going to be very useful in your practice. Yeah, another advantage of this file is the chances of canal straightening is comparatively. When you are using the ProTaper or Neodent, all these things, I am using those files also. When you use that, chances of canal straightening is comparatively high. When you use these files, that is Desai file, chances of straightening the canal is comparatively less. Yeah. So what taper? Will you go with a bigger taper or smaller taper? Yeah. Will you go with all the canals, all the cases should we use a bigger taper or a smaller taper? So again, that depends on the apical width. So now already apical width is very small. If your tent size itself is very difficult to travel inside the canal, use a 4% files. That is 4% 20 or 4% 25. Those files can be used. The canal is big. That means your tent size file is easily going inside the canal. You can use your 6% taper. Okay. If the canal is very small, initially itself, don't try using a 6%. The chances of file unwinding will be comparative. It won't break easily, but it can easily unwind. Okay. Clinical selective situation when you should use a smaller size tapered file, that is intentional root canal treatment. It's always better not to use bigger tapered file because there is no debris or microorganism inside the canal. Your idea is just to remove the pulp tissue alone. Yeah. In such cases, you can go with a smaller tapered file. In case initial apical file is very small, that is your tent size is very difficult to go, again you can use a smaller size tapered file. MP2s again you need not enlarge to bigger size tapered files. Yeah. Extremely long and curved canals, thin rooted mandibular molars, all these canals, preferably not to use a 6% tapered files. Yeah. If you use a 6% tapered file, chances of perforation is very high. Can you see here? This is the original canal size. When you use a 4% taper, the enlargement is like this. If you use a 6% taper, this area becomes more thinner. Okay. So how much should we enlarge? How much should we enlarge?
Depending on the apical gauging.
Yeah, depending on the apical gauging. First initial file difficulty based pannidha. But according to a lot of study, they show that the apical diameter or minor diameter is almost around 0.20 to 0.30 or 35. So that means the apical minor diameter width padachna 0.20 to 0.35. So that much at least you have to enlarge. Apical diameter size is 0.20 to 0.35. And there is a study which is done in 2000 and they have shown that when they have used 20 size or 25 size 4% file, the irrigation was done using your saline as well as sodium hypochlorite. Amount of debris removal was equal. When they have used a 35 size, the enlargement as well as the microorganism removal was comparatively higher when you use a sodium hypochlorite. So that means the optimal enlargement of the canal should be at least 35 size. Yeah, 35 size. That is, you can start with the 20, 25, 30 and 35. But whether it is practical for every other case, that again depends. So at least optimal enlargement should be 35, not more than that. So this is the case which is done using a 4% taper. Can you see the final obturation is very thin. Basically the canal is also a curved canal. So that is why we have opted for 4% and it's also very small canal where you won't be able to see the canal properly, the X-ray. In such cases, 4% taper just to enlarge the canal using or create a glide path with your tent size 15, 20 and then you can start with the rotary file. And if the canal size is big, in such cases big canal, probably you can use a 6% tapered files. Disinfect the remaining space. It is a continuation process, start to end. It is not a separate process. When you are doing an access opening, when initially enter inside the pulp chamber itself, you have to use your sodium hypochlorite irrigant, and your either distilled water or saline you can use. Yeah. So sodium hypochlorite is a must. Along with that, you can use different irrigating devices. So this is a sonic agitator, just to agitate the irrigant inside the canal. And this is, have you seen this? Irriflex. This is a side vented needle. This is available from PD. This is an excellent irrigating device which can be used, and it is having a tip diameter of 0.30 and taper of 3%. So when you enlarge the canal 30 size, this irrigating device can easily travel inside the canal and can irrigate the canal completely. And this is a device which I use in my practice to create a negative suction. What is the idea behind doing a negative suction? Like canal should be completely dry, yeah, before obturation. If you are using a bioceramic, it can be still wet, yeah, but otherwise it should be completely dry. For that you can use a tip from Caterpillar, or it is called as Caterpillar tip. This is available from Colteen, and this is another tip from Navy tip which is available on Ultra Tent. Yeah. So again I have a story to tell you. In 2012, when I completed my completed my post-graduation, I used to go to different clinics and give my resume. So every other practitioners or big named practitioner, they used to say me, how much time will you take for completing a root canal? So I normally tell probably 45 minutes to 1 hour. Yeah. So those big names in dentistry, I'm not against those people, but they used to say me that my endodontist right now takes hardly 20 minutes to complete the root canal. So over a period of time, as we acquire a lot of knowledge, according to this particular journal, they have shown that for an anterior teeth, it takes around 10 minutes of irrigation is necessary. For a premolar, it needs around 12 minutes of irrigation, and your molar should be having 15 minutes of irrigation, minimum 15 minutes of irrigation. That doesn't mean that you have to continuously irrigate for 15 minutes. From start to end, at least 15 minutes of irrigation should be necessary for a good predictable result. So that means irrigation itself will take this much of time. You cannot complete a root canal within 20 minutes. If you are doing such kind of endo, I think the predictability will come down, as all of you know that tooth is so forgiving. Even if we are not doing such kind of irrigation protocol, still sometimes it will stay inside the oral cavity. So try to instill or try to spend more time in irrigation. Okay. And finally, you have to obturate. So before obturating, you have to do something called as a master cone check. Okay. So master cone check, normally you can use a GP, or you can use a nickel titanium file also. Okay. So I use a GP to insert the GP inside the canal and check the master cone. Sometimes what happens is there will be a scratch mark at the tip. Sometimes there will be a scratch mark at the middle portion, or sometimes there will be a scratch mark in the coronal portion. What does it mean? What does it mean? So I think a lot of people would have done a root canal, and when you keep the master cone, it is not going up to the apex. GP short again. Now instrumentation complete upon 6% 25 but 6% 25 GP is not traveling or going inside the canal. Yeah. In such case, take the GP and check closely. You will be able to see some kind of scratch mark either at the coronal portion, or the middle portion, or the apical portion. That means your orifice enlargement was not good enough. If in such cases, your scratch mark will be in the coronal portion of the GP. If there is any scratch mark in the middle portion of the GP, that means there is some middle indifference. Yeah, middle third indifference. That means your instrumentation was not circumferential. You have to do a circumferential enlargement of the canal using the rotary file. If there is any apical indifference, in that kind of condition, your GP will be bent. So that is called as pigtail in so. Pig got a tail, அதே மாதிரி ஜிபியும் வளைஞ்சு போகிறதுக்கு காரணம் என்னன்னா apical enlargement was not good enough. Okay, so you can check that before obturating. And sealer never to be used, நம்ம எல்லாருமே யூஸ் பண்றது தான். What is that? Your sodium, sorry, your zinc oxide eugenol. It should not be used, and there are a lot of study to show that there will be a lot of cytotoxicity with your zinc oxide eugenol sealers. There are different other sealers which is available right now in the market, preferably bioceramic sealers, or you can go with something like a resin sealer, better than that of your zinc oxide eugenol sealers. Clear? Why bioceramic? These are the reason. It is definitely more biocompatible. It is more hydrophilic. When you compare with all other different types of sealers, this is more hydrophilic. All other are hydrophobic in nature. So it is hydrophilic in nature, and the dimensionally stable. All other sealers will resorb, or over a period of time will shrink. So the chances of such kind of shrinkage is not there for bioceramic sealer. So if you can shift to bioceramic sealer or change to bioceramic sealer, that will be great. So these are the different bioceramic sealers what I use in my practice. Mainly CeraSeal, it is an Indian based company, cost effective. Probably 2 grams it will cost you around 1,800 rupees, and this one is comparatively costly. Septadent will cost you around 4,000 rupees. So it's always better to go with a cheaper option. If you can buy BioRoot, or the patient is capable to do bioceramic sealer using BioRoot RCS with Septadent, that would be great. And this is a pre-mixed version of bioceramic CeraSeal. This again will cost you around 7,000 rupees for 2 grams. Yeah. So yeah. So either in my practice, what I do is I mix this powder and liquid and use the GP to obturate. If the patient is capable of, or if the patient is ready to spend more money, I can go with the CeraSeal pre-mixed version. I can inject inside the canal and obturate. There is no need for GP itself. Okay. So preferably, if you feel the chances of reinfection is comparatively high, go use along with your GP. Okay. Because CeraSeal mattu use panni anterior la obturate pandringa vechuko. If you are using CeraSeal alone, you need around 1.5 grams of CeraSeal. That means obturation itself will cost you around 7,000 rupees. It is not economically feasible, right? So in such condition, you can use along with your GP. Again, if you are using a bioceramic, no need to do a lateral condensation. You can use a GP, smaller size, or any kind of GP. Along with that, you can use CeraSeal or bioceramic. So take home message, as we know, axis opening, canal patency, orifice enlargement, true working length, apical patency, mechanical or rotary glide. Mechanical glide path in solver using your normal K files, that is your 10, 15, 20. Likewise, rotary glide path, we have a Jezai rotary glider, you can use that. Recapsulation, larger tapered rotary files, that means your 6% or 4% rotary files. And finally, gauge the canal using the GP, okay, and finally obturate. Got it? Now the tooth is almost like this. I'll take another 10 minutes somehow. So right now the tooth is like this. After doing obturation, it will be like this, right? In many cases it will be like this. There will be a lot of sealers here on the floor. Okay. So if you use in such condition, if you are using composite, it is not going to bond. As doctor has already said, even if you do a selective etch or total etch, it is not going to have a good bonding. So in such cases, you have to completely remove that sealers, any kind of sealer, even it is your bioceramic or your resin sealer, and even if you are using any endomethasone or eugenol based sealer, definitely that has to be removed. And preferably, in case if you are using a eugenol based sealer, remove little bit of denting before bonding, or else there won't be a proper bonding. Okay. So what I use is, I use MI bars to remove this structure. MI bars mainly remove the dentin alone, or infected dentin, or the surrounding dentin, as well as the the sealers alone, or else even you can use an alcohol rub. You can use not spirit, separate alcohol rub can be used, or you can use your normal round burr also, diamond round burr also, but you have to be very careful. Or you can use your ultrasonic tip without water to remove that sealers and then go for a bonding. Final restoration parts are post, your core and definitive restoration. Again, post, as all of you know that, what should be the length of the post? It should be equal to that of the coronal structure. Minimum. Okay, that should be the optimum. And if the length of the post is not good enough, it is going to be failure and it will result in fracture. Okay, what do you mean by ferrule? Yeah, circumferentially there should be a ring. This is your ferrule. Okay, this is a ferrule structure. This ferrule structure, at least it should be around 1.5 to 2 millimeter. The ferrule structure circumferentially, if there is no this ferrule structure, it is going to be the predictability will come down. Yeah. So how can you create that? In this case, this is not my case. In this case, there was there's a deficient ferrule. Okay. So gingivectomy was done using a laser, and then post was placed, and final result was post was placed and finally restored, right? So this is another case of mine where the ferrule was very less, circumferential ferrule was not there. So again, gingivectomy was done using laser, and this is the ferrule structure which is available. Again, it was not done using rubber dam. Yeah, and this is a ferrule, and then post was placed, and finally the core structure was built. Yeah. This is another case where ferrule structure, chances of biological width, you should not should preserve the biological width, right? So in this case, gingivectomy is not possible. In such cases, you can do something called as an extrusion. So orthodontic extrusion was done, and finally the core structure was built. You see here there is no ferrule structure. So orthodontically it was extruded, and then post was placed, and then core structure was built. And another thing is that core structure is always better to go with composite, not with something like your GAC or your amalgam. It's always better to use your composites. Again, next question, which post, metal or fiber? Why? So study shows that the success rate is almost same. Fiber post potalo, metal post potalo is almost the same. Only thing is that survivability, that is, if it fractures, metal post is going to be catastrophic. That means it can fracture in such a way that you cannot redo it. If you are going with a fiber post, chances of redoing is very high. Even if it fractures, you can redo it. Okay? So survivability is almost the same, but if it fractures, it is going to be bad for your metal post. Core structure, as we already discussed, it should be composite, and from Money they have different composites which is available. Money Flow V is an excellent material. Basically, it is having high viscosity. High viscosity means low flow. So normally when you use a flowable composite, what happens is it will flow easily or it will slump. So in case of reattachment, you can try these kind of Flow V, which is having less flow, so it will adapt easily also. And in case if you are going to do something like a deep margin elevation, DME, in that cases also you can use Flow V. It's an excellent material, and they have something like Money Nano as well as Micro. Micro can be used in case of anterior aesthetic restoration, and Nano can be used in case of a posterior restoration. And Money bonding agent, it is a 7th generation bonding agent. It is also called as a universal bonding agent, but this is a 7th generation. What is the difference between 7th and 8th? and 8th. Have you heard about MDP?
NDP model.
Yeah. So it is a universal bonding agent. Then generation is a universal bonding agent where it adapts with metal, ceramic, or anything. Whereas sample generation, it is not having MDP resin in it. It is not having MDP resin in it. Still, we call it as universal. What next? Once the core is done, what is next? Obviously crown, right?